Wahu, in her mid-40s and recovering from 2 miscarriages, faced her next pregnancy with a heart full of hope and anxiety. Every morning started with a question she was too scared to voice. Is my baby truly okay? Her doctor offered her a lifeline, NIPT, non-invasive prenatal testing, a simple blood test done as early as 9 weeks of pregnancy, analyzing fetal DNA in the mother's bloodstream to screen for different genetic conditions. But clarity came at a cost. Here is Wahu's story.
For Wahu Kagwi, her third baby girl was different. She had already endured the pain of 2 miscarriages, and now, in her mid-40s, she found herself expecting again, cautiously hopeful but deeply anxious.
My biggest concern is this baby healthy? Is this pregnancy healthy? Because before I had lost the pregnancies, because what I would be told, that there were first trimester losses. So what I'd be told is, it happens, it's natural. It means maybe the baby was not going to be able to make it in life, or whatever it is, maybe hormones, I don't know.
With age and history raising the risks, Wahu was offered a test that promised clarity in the unknown.
I'm in my mid-40s at that point, and I'm like wanting to know, is my child going to be okay? Based on my age and based on the fact that I've been told that as you grow older, that it may be more risky to have a child. So that's why, a child with an issue. So that's why I wanted to do the tests.
It was early in her pregnancy, around 10 to 12 weeks, when her doctor recommended the NIPT, non-invasive prenatal test, something that wasn't previously familiar to her.
I had never heard of that kind of test before, ever. The only experience I had had before with pregnancy was inaitwa nini? Scans. The usual things you do, just the usual medical things that you do. That's the only experience. So I'd never heard of a test to see if especially at first trimester? Yeah. So we start looking at options. And I'm like, just tell me where to do this test.
NIPT, non-invasive prenatal test, is a blood test that analyzes fetal DNA circulating in the mother's bloodstream. Without touching the baby, it screens for the likelihood of congenital conditions like Down syndrome, among other genetic conditions, including the baby's sex, early and safely.
So what NIPT in essence is, it's actually blood work, so they check. So which was interesting for me, because I'm like, the baby's DNA is just randomly floating in my blood. Like, really, you're not going to get to the baby. You're just going to check my DNA. And she's like, no, unless we need to. The first thing we're gonna do is check your blood. I'm like, okay, now I know that the toy's DNA is somewhere in my nini. So in my bloodstream, yeah.
But with reassurance came a financial reality. The test wasn't cheap.
No, the costs were crazy, because there was a place where he told me it was going to come to like 120,000, and I'm like, how for a test? 120,000. In my head, I'm like, who's ever able to afford this?
Still, for Wahu, peace of mind outweighed the price.
I was willing to do it because for me it was very important to know, But at the same time, I'm like, my goodness, like that is not fair that it is this expensive yet this important.
After the blood sample was drawn, the wait began. The results would take 7 days as the sample was shipped to a lab in London.
Wow, those 7 days, hey, they were the most, is the word nerve-wracking? Because you don't know what's going to happen. It was such a difficult 7 days. What I remember is the results were coming in on a Sunday. The 7 days was showing on a Sunday. So me, I'm here, I'm seeing the blood work has gone. I'm tracking because I just have to track. Blood work tumefika hapa. We are at now 50% done testing. We are now at 70%. I'm like, oh my God, I'm so anxious.
The results confirmed that her baby was healthy with a 99.9% likelihood of being free from major genetic conditions.
She messages me in the morning and she tells me, congratulations, check your mail. Aki, I cried. Oh. I cried. I was so happy. I couldn't believe. It was... What? It was the best news I've ever had because I was saying, how is it possible? Like, me? Why me?
For Wahu, NIPT wasn't just a medical test. It was a turning point. From fear to hope, from anxiety to peace. The results allowed her to carry her pregnancy calmer and confidently.
I tried to imagine waiting for 9 months without really knowing, vis-a-vis waiting for 9 months with knowing. For me, it is made the world of a difference because I would have been anxious for 9 months as compared to being anxious for 7 days. So it made a huge difference in the quality of my pregnancy as well.
But what if the results had gone the other way?
It would have been devastating. It would have been very devastating. It would have been difficult. Like I said, I would rather know so that I can be mentally, whether it's mentally prepared, or at the very least make a decision based on information, not just on hope. I'm able to make a decision based on this is the reality. This is your reality. How do you want to move forward? That gives you a better way to know the right decision for you. So it would have been devastating, but I wouldn't do it any other way.
For Wahu, NIPT wasn't just a medical test. It was the lifeline that turned fear into assurance and anxiety into peace. In a world where every heartbeat counts, knowing sooner can mean loving stronger and choosing with confidence. Because every mother deserves not just hope, but answers. For Code of Life, I am Sarah Kamande.
To help us make sense of it all is Dr. Catherine Mutinda, who is a pediatrician and geneticist. She works closely with families across Kenya to understand inherited conditions, children's developmental changes, and the tough choices that sometimes come with knowing more about our genes. Karibu sana daktari, welcome to this Code of Life series. And for us to start this conversation, we'd like to understand your journey. What drew you to the world of genetics after doing pediatrics?
Actually, it was genetics first, then pediatrics. So I went to medical school knowing that I would become a doctor. But if you look at myself and my brothers and my sister, I'm the smallest, yet I'm the eldest. So I was already curious from that point. Mm-hmm. I just wanted to know, what is this that decides this? And I'm thankful to my mentors in my undergrad. I met a mentor who was into galactosemia for all his life, and it's a genetic disease. Mm-hmm. And that's where the fun started. I was so interested in just doing genetics, wanting to understand the code, the puzzle. How does this piece fit into another piece. So that's how I ended up being very, very interested in genetics, genomics, and also the whole idea of how do you translate what's in the lab into the clinic. I'm talkative, but I also have my time. I want to just understand stuff. So having done my undergraduate, I came back and I wanted to finish my internship and go straight into genetics. And then I realized then I have a missing link. I wouldn't have this array of knowledge of how to talk to children, talk to parents, talk to the family. So that's why I pivoted towards pediatrics, because it's more or less you're dealing with the whole family at large. I enjoyed pediatrics, and shortly after that, I started that story again. The itch came back, and I needed to do genetics, and I talked about genetics. And until my mentors had had enough of me, and they sent me away to do genetics. So here we are.
Okay. So for a lot of us, genetics may feel like it's a far away concept or thing, or that's something that just makes up our DNA or our form as human beings. So what does genetic counseling mean for a mother-to-be or a young couple, a parent-to-be, especially when they notice something about their child, or is it that something that happens in the family first? Which one comes first?
So genetic counseling is a conversation about yourself. So generally, you can say that the modern world has given it a name, but our traditional African world gave it a name. It's those ceremonies where your grandparents told you the folklore about your people. And now they talk to you about your warriors. You're supposed to be strong. You're supposed to be that. And those are things that they saw as what we'd call today phenotypes. So they were telling you their genetic lineage. They're telling you are of royal family, or you are from the workers' family. So it's a discussion. It's a conversation about how we live and what makes us us. So genetic counseling, in a way, is a dialogue to understand what your risks are, health risks, as well as what are your potentials. For example, we talk about cancer. Cancer is really a big menace today. So is your family prone to cancer? Let's have a conversation about that. What are my risks? Can I change my lifestyle? Is there something I can do to prevent getting that cancer? Although it runs within my lifeline, what can I do? So that's about genetic counseling, having that conversation really about self, family, and society.
So you want to mean when our, say, grandparents or extended family ask for the clan or where does this person that you intend to get married comes from, is that, an traditional, unofficial, non-scientific way of genetic counseling?
Correct. That is the process of genetic counseling. So occasions where a young lady and a young man wants to get married, most traditions say the families should meet. And during that family meet, they go through the family history. And the family history is, in genetics, called the family pedigree. So who is married to who came from where, were there diseased children, who died of what, and then now we see, are we eligible to come together as a family? And the family can say, no, you can't marry each other. Why? Because you're related, or in their family, they have mad men, so we don't want you to have mad children. So all that was actually genetic counseling, unofficial. They understood what was going on. So they had that conversation. So today, the modern genetic counselor is actually also having that conversation, now without folklore, but more of scientific evidence that if you have, say, epilepsy, there is genetic epilepsy. And this is caused by these changes in your DNA. And this can happen to your children or not happen to your children. And this is how it is passed down. Yes.
Okay. So why in this day and age, and you've talked about, one of the reasons is whether some of these diseases can be inherited and passed on to the next generation. For women listening or watching, why is it important in this day and age to go through genetic counseling, or, just go through that process of understanding our genes and what we have?
I think one of the basic rules of life, or I think it's one of the laws, is that you don't want to reinvent the wheel. If, for example, you know for a fact you're a sickle cell carrier, and by God's grace, you are deemed with knowledge that your partner is going to be a sickle cell carrier as well, then you know you're going to have a sickler. Do you want to go in and have a child who's going to have a very poor quality of life? Or do you want to avoid that? So basically, it is empowering you with information, with knowledge of what you can do with your love life, what you can do with already existing couples. We are not saying you should not marry each other, but what are my options? So that I do not have to incur so many health and social and a lot of ethical issues around what do I do with this child who is not going to be self-sustaining, who cannot go to school, who cannot talk. I mean, there is a lot as a woman. You should be concerned. We are the people who take care of the family. So does it mean you have to give up your job to sit at home and take care of this child? Are you willing to do that? And if you're so willing to do that, what support do you want to get? Maybe from government, maybe from family. How do you need to plan that? So we're helping you have that information within your reach and then make a decision for yourself and for your family.
So in your practice, Dr. What are the common reasons why people come to you or are referred to you? What is it that happens within their lives, their day-to-day, that they end up,
with me?
Yeah,
yes.
with you.
So sometimes they say I'm the doctor of the family looking child. So this child does not look like the other children, is not able to walk on time, speak on time. So they end up coming and saying, my baby is not doing this or that. And sometimes it can be within the norm, and sometimes it can be outside the normal. They look funny looking. That's what they say. They don't look like the rest of us. Their ears are way too low. Their eyes look more like Chinese eyes. Then there are those who come to me because we have tried all sorts of medications to treat, let's say, a convulsive disorder, and we are not getting anywhere. So are we dealing really with convulsions, or is there something more to this? So there are also a diagnostic challenge to the doctors who are taking care of them. Another group of people who come in is those who say, in my family, we have seen my uncles, my aunties dying very young of cancer, and I'm worried about myself. Will I get cancer? And if I will, what type of cancer? What should I do? What are my chances? Then we have parents who already have an affected child, as we talked about sickle cell earlier, and they want to have another child, but they have seen the struggles of this one child, and they want to know, are they going to try again to get another child and get another child who's also going to have challenges? So different array of people. People want to know their risks. People want to know their diagnosis. People just want to educate themselves on what their chances are.
What of women who've suffered, say, multiple pregnancy losses or even loss of children after birth?
Yes. So that's another very important group of women and ladies who have tried to conceive, or couples who have tried to conceive, and multiple times they have lost pregnancies. And also had pregnancies come to an end, had a child, and the child has died shortly after. So they have had more than one loss. Actually, most of the time they come in when they are on their third and they are trying, and the doctor says, we can't go on like this. I mean, you can't just get pregnant and we keep on losing in the first trimester or immediately after birth. So we come to have now the diagnosis and trying to understand what exactly is happening in this couple.
So as an expecting couple or a pregnant mom, if I come to you, what does a typical session for genetic counseling look like?
So it will look like if you're coming to what the Kikuyu says, Korasheria. So we'll take a family background, your family pedigree, see whether you are related in one way or another to your husband, except by marriage. That means consanguinity. Then we will understand from your point of view what your concerns are. Are your concerns, say, for example, age? I'm an older lady. I've been in my career, and I'm in my 30s, late 30s, 40s, and this is my first child, and I just want to I'm scared. Or I am a young lady, I'm in my 20s, but I have lost 3 or 4 pregnancies, so I'm also scared that I'll lose this one. Or in my family, we've had children who have had challenges, so I'm also worried. So that's how we start. We start off by understanding the patient and also understanding the question the patient wants to answer. So you do not infer a question. the patient has to tell you what they want. Sometimes the patient just wants to know that they're having a good child. So we have things like non-invasive pregnancy testing that starts all the way from 9 weeks of pregnancy or a bit later. There are ethical challenges. There are people who will come to me and say, I have 10 girls and I'm looking for a boy. And I am pregnant. I want to know, am I carrying a boy? So if you say that to me, I'll probably not test you, because if it comes out as a girl, what are your chances of keeping this girl? Yeah. So it's not about you trying to choose the sex of the child. It's about a situation where there are quality of life issues being discussed, health issues that are being discussed, empowerment issues that are being discussed. So there are ideas of getting a tailor-made baby. That's not the idea of genetic counselling.
So it's about really identifying and diagnosing maybe those rare conditions or inheritable conditions like sickle cell, so that parents can know early.
Yes.
Okay.
And also prepare themselves
Psychologically for
Correct.
it. Okay. So what kind of tests, if any, do you do, or is it just because when you hear counselling, we just think we're having a conversation. I've known, bye, see you. Are there any tests that you do, and what kind of tests are these?
So just going back to counselling, counselling is not therapy. This genetic counselling is not genetic therapy. Counselling, we are giving you information. Then you're asking a knowledgeable person what that information exactly means. Then you can move into now the genetic testing, where we are now talking about these are the tests that we'll offer. So for a pregnant lady who has come in and she has no other diseases, or she's not squabbling with anything else except that she's more worried about her pregnant, the baby she's carrying. So we start at around 9 weeks with something called non-invasive pregnancy testing, which means we take the mother's blood, the maternal blood. The moment we are around between 7 to 9 weeks, has fetal DNA already, free fetal DNA circulating within her stream. At 9 weeks, it's actually a lot, enough for us. We can do it a bit earlier, but 9 weeks is optimum. And we take the fetal DNA, and from the fetal DNA, now we ask the basic questions according to the patient. Does she want to know whether she's going to have a child who has a trisomic, like Down syndrome? Or is she worried, which would mean that we advance this genetic test to look at even microdeletions as early as 9 weeks. Yes, we can also look at sex-oriented disorders. That's when we are even able to tell you whether you're going to have a boy or a girl. You understand? So all these things can be done as early as 9 weeks. So sometimes you find yourself, you've done the 9-week test, and unfortunately, you found out that you are waiting for a trisomy 21, which is commonly known as Down syndrome, and the parents want a more confirmatory test. So a more confirmatory test will happen between 18 weeks to 20 weeks, where we actually go for the fetal sample, which is going for the amniotic fluid or the placental sample. And then we test to confirm. Yeah, it's called a CVS or an amniocentesis. Those two will confirm for sure what we have found. Now, in the CVS or the amniocentesis test, you can go even further and decide on diseases like epilepsy. You can decide whether this child might have maybe an inborn error of metabolism or even inborn errors of immunity. So there's a lot we can do during pregnancy. Our idea is during pregnancy, our cutoff is at 6 months. So by 24 weeks, by the 20th week, we should have provided this mother all the information she requires to make a decision on what she needs to do.
Are these tests available in Kenya?
Yes, they are all available. We
And
live in a
affordable.
global village, so everything is available. I would say on affordability, the costs are coming down. I came in when the costs were a little bit higher. We've been doing a lot of advocacy work behind the tents and discussing with a lot of labs. There are some issues around our laws that need to be corrected and changed a little bit to accommodate molecular science. However, they are available, they are accessible. Not as available as I would wish them to be, but I think we are working.
So looking at what's happening in this day and age, where the career woman would delay childbirth as much as possible, what would be your advice? Because we tend now to see women establishing their careers first before they get any children, is it then advisable that before now they get children, especially after the age of 35, that they consider genetic counselling and testing?
I trained in England, so at 35, anyone who's pregnant after 35 has a standard NIPT provided.
The non-invasive pregnancy testing.
Yes, they have a standard one, which is not available for us right here. I would not, maybe I'm a feminist in this way, but I would not say that everybody who is older is going to have a child with a challenge. Surprisingly, literature shows that trisomy 21 babies are of young mothers. So it's not all about age. Age does play a part, but it's not the only thing. And it's not only maternal age, also paternal age plays a role. So I think there's that, it's like the MMR story. It's that story that has always been peddled. The woman's clock is ticking, and she needs to hurry up.
You need to do something after 35, then we are even calling you an elderly mother.
I think that should not be one of the biggest things. What I would say, even when you get into reproductive age, I'm blessed that I have actually counseled an 18-year-old who's thinking of getting into marriage about genetics. And she was very upfront. She wanted to know. She wanted to see whether she's compatible with her mate. I think all of us have to have that conversation. And it's not about whether you've started a career or not. It's about having that conversation to discuss your chances, whether you are older or younger. So there's a lot more emphasis in the older not career woman, but in the older lady. Yes, but it is not absolute.
And it's not a woman's only thing.
Yes.
Okay. So in your practice here in Kenya, what are the most common genetic conditions that you see that families may not have realized could be inherited or that can be screened for?
Okay. Most of them are developmental disorder, global developmental disorders. Prime is when the baby is not walking by the age of 2 or not speaking. So that's where they start coming in. They start off with their general pediatrician. If blessed enough, they will pass through a developmental pediatrician before they get to me. And most of the time will come with global developmental delay. Other issues are around seizure disorders, which are closely related with developmental delay. The next group of people are to do with the funny-looking child, the ones who are trisomic and they just look weird. And yeah.
You know, those children are like,
there
seems to be, but I'm not sure. Yeah.
Exactly. Yes. I just want to put out there that it is not paternity. Because everybody who has genetics thinks we're going to check whether you're the father of the child. No. In fact, I don't do that because that has to be court-ordered. So we don't do paternity. And paternities are usually linkage studies just to see whether families are related. So we don't do that. We are actually here to diagnose medically doable things, like we can have a solution to this. I also get a lot of inborn errors of metabolism. Children who are having diabetes very young. So we have newborns who have diabetes, which is already acceptable. But when the doctors are actually using a lot of insulin, more than is recommended, then they start wondering, what's going on here? Is there something more than this diabetes that we are treating? And that's where we come in and start saying, now we need to understand what we should do. We are trying to treat maybe an epilepsy. We can't get it right. The drugs, we have optimized them very well, but the child still convulses. We need to come in. I have clients who have cancer, early cancer, breast cancer at 20 years old is genetic. You have to come in. We have to check what's going on. I mean, there's a very big story out there about the Angelina Jolie story, why she had a mastectomy. Yes, and that is to do with information she got from genetic counselling that she was at risk. So she did something about it. So that's all about, that's what we do generally.
So I'm always wondering, when a child is developing, sometimes they may have delayed milestones and they'll pick up. Correct. So at what point does a parent pick this as an issue and not that, they're just delaying, but they'll pick up. Other people have delayed, but they've picked up. At what point should it be worried?
Of concern.
Yeah.
So if you look at the purple booklet, the Ministry of Health purple booklet, there's actually a page on child development. And at each stage, there's something we expect the child to have attained. At 2 weeks, we want you to have head control so that you're not wobbly. And if you're still wobbly, at 4 months, I should be now very worried.
Okay.
You understand? We want you to, there's a range we give you. We give you from 2 weeks to 2 months to get your head control. If at 4 months, you have not gotten your head control, something is off. Something is off. We expect you to be able to breastfeed right straight from birth. You're not breastfeeding. You're not a prem. There's something off. You understand? So it can be caught by simple charts that we've been trying as pediatricians to get people to use. Their charts are in their booklets.
We don't read that.
We don't read those booklets.
We wait for you to tell me
Where
is
the
my child
vaccine.
is doing okay or not, and then you remind me it's time for your vaccine.
Yes. So there's that booklet, there's that chart. Check. My daughter is supposed to be smiling. Is she smiling? No, she's not smiling. Does she have head control? She's not. Is she able to turn? She's not turning. So that by the time we are talking about walking, we are really late to the game.
Okay.
Is she sitting? She should sit by that. Should at least pivot, try to sit up by around 3 to 4 months. If she's not even interested,
There's a problem.
there's a problem. And then as mothers, let us not shy off from insisting. If you don't get an answer from me because, as we say as African, damu zetu haziendanishi, move. My class was of 40 pediatricians. For crying out loud, I'm not alone. Move to the next one. Ask, Daktari, my baby is not able to turn. We are 6 months old. What could be the issue? Mothers know. Mothers can tell, Appa, something is off.
Even for new moms, you always feel like,
Yeah.
no, there's just something not right. And even from the stories that we've done when doing this story, the mother always had something at the
inkling.
back of their minds that, there's something not right in this situation.
Yes, I was just having even a conversation with one of the colleagues, and she was saying, as doctors, sometimes we have not been taught how to have that conversation, that deep conversation of, something is wrong. Telling a mother that something is wrong feels like we are selling out, like we are not providing care. So as a health system, as a society, we have also to live with each other and accept that some doctors are able to talk more openly than others. So if your doctor is shy, I've had patients who have obvious Down syndrome and their pediatrician has told them they will heal. We all know they won't heal. But the doctor is also having a hard time to have that conversation. If you're finding that is your situation, you're not pivoted or tied to that. You can move to the next doctor and have the courage to say, I am sad, I am concerned. This is an issue. What I would like to say we shouldn't do is go on to Dr. Google, my biggest competitor, and Miss Instagram, who is also a competitor, and then now we start. Go to someone you have. You can check their qualifications so that you can have a conversation with the person who is actually qualified. Sometimes we find mothers who have children with challenges get entrapped, I would say entrapped into a false hope. Where of late I've been dealing with issues with stem cell transplant that is being offered in India. I just want to say health is not a secret. We are not witchcraft guys where we have the secret concoction hidden. If something is working, it is published. If something is working, the person who made it work has been recognized for doing a great job. And we will all of us support that for our patients. However, if someone is calling you to a restaurant to discuss a new therapy without any of your local doctors, please be worried. Something
It should raise an alarm.
Yes, something
But
is off.
I find that people are going, say, to India and those other places for such therapies because they've been sold hope more than I think they're going
reality.
for hope more than the treatment that they're going to get. So is there like one example of, in your practice, of somebody that you've taken through the genetic counselling and testing successfully?
Yeah, we actually, as a very blessed. I have so many of them. And if this is your story, excuse me, but we've had a mother who's older mother. She got pregnant, and she came and we had a conversation, and we ended up doing the testing because she wanted to know what the situation is with the new baby, the unborn baby. And the baby was unfortunately having trisomy 13. And what we know about trisomy 13, it's incompatible with life. They would probably get to birth, but they would die shortly after birth. And we had that conversation with her, and we just laid everything out for her. And she had a conversation with her husband, and they agreed to have a termination. After the termination, we came back and had another conversation of how she felt about it all. And she has daughters, and she actually called in her daughters, and they had a conversation. So I felt like when I meet her, I still take care of her other children. She's a very happy mother. She's like, I know in my heart, I would not be able to take care of that child, and I would have been more broken than anything. So I think that was successful. It was a bad outcome, but it was successful. The other one, she had an extra Y chromosome. They are not Kenyan. And we had a discussion, and we had the results come out. And because they had tried for a very, very long time to have a child, they decided to have this child. And of course, they knew there were going to be challenges. And of course, the child was born, and there were challenges. They were not Kenyan, so they decided to go back their European descent and have the child taken care of in their health system, because they have a very good health system where they came from. The child would probably be on a vent for long, but it made this mother feel like a mother. That's what she wanted. She wanted for once to transfer life to another being. And for her, she felt that was good. You may not agree with her, but genetic counselling is not agreeing with the patient. It's giving the patient what feels right for her.
So from what I get, it's just about the patient making an informed choice and decision from whatever information comes from the counseling and the testing.
Yes.
Okay, so let's go back to NIPT, the non-invasive prenatal testing. How is it different from the regular, ultrasound scans that you do, or the blood scans, the urinary test? How is it different, and why should I, if I'm an older mother or, a woman at that age, think about it and take it more seriously?
First, we are coming in at around 9 weeks, very early. We come in very early before even an ultrasound can pick up organs. So the ultrasound will pick up the organs at around 18 to 20 weeks. That's when you'll go for your anomaly scan. We are coming in 9 weeks earlier. We are coming in when the embryonic sac has just been made, to tell you what the establishment looks like. We are coming in at that time so that you have a choice, a socially correct choice. Because at that time, who knows you're pregnant?
Only you.
Only you.
And your partner.
And your partner, who might not know.
Might not know, actually.
Yes. So we're giving you a chance to not only do something that is secret to you, but also available to you, that will not stigmatize you to the society. It's different when we've seen your belly growing and then suddenly we don't see it. And now we introduce another stigma to the mother, another social problem to the mother. We're not supposed to provide other problems, supposed to provide more solutions. Yeah. So first things first is as early as possible. As early as possible. And when we're doing an NIPT, we'll turn it around in 5 days. We'll give you your answer, maximum 7 days. But we will answer you before you're 10 weeks pregnant.
So why do
you do this? So that if you want to make the decision, as I said, a lady made a decision to continue with your pregnancy, then you can make the necessary arrangements, maybe with your insurance, with your partner, whether you will deliver in Kenya. We've done that in Kenya for Kenyans, where we have actually set up the delivering team. Like, we need a cardiologist present, we need this one present. We have set that up for you, so that now you have a whole 8 months or so to prepare psychologically, to prepare, your money and everything else. Yes.
Even the right support.
Yes.
So what does the NIPT check?
It checks the baby's chromosome 1 anomalies. So there are two types of NIPT. You can do what we call the basic NIPT. Basic NIPT just checks the ones that we know are commonly happening: trisomy 18, trisomy 13, trisomy 21. In English.
In English, please.
So for we are made of 23 chromosomes, and these 23 chromosomes are paired. So a pair is 2. So when we say number 1, there should be 2 number 1s. Number 2 should be 2. So if we have an extra, that means we are trisomic. So we have number 21 has a tendency of coming in 3s.
So that's the Down syndrome.
Yes. So trisomy 21 or 13 can come in 3s, or 18 can come in 3s. We have an X chromosome and a Y chromosome. XY is a girl. Is a boy.
A boy. XX
is a girl. But there are times where we have XO. There's missing one. Or we have double XY or double X. Double Y.
Double Y.
Yes. So we have extras. So the basic NIPT looks at the basic ones where they are known to have common extras. Then we have an advanced NIPT. Advanced NIPT means we are not only looking at the basic ones, but we are also looking at something we call microdeletions, small changes, duplications, small changes in areas that we know happens. Like we know that you can have a trisomy, small portion of Q21. So a small part of the 21st chromosome can be trisomic, can be very troublesome. You can also have things like inborn errors that are associated with microdeletions. So those are the things now the extended NIPT will look like. We'll look at. There is a molecular NIPT that is being tried, whether it will be sensitive enough to also look at sequencing that fetal DNA. But we are not yet into the commercial part where it's available at the clinical setting.
Okay. And when you're having this conversation with a woman or the couple, what are the ethical considerations or worries and concerns that they have? Of course, the termination of pregnancy is the biggest one, particularly if you know definitely that, at the end of this pregnancy, the condition is not compatible with life. So what other worries do women have?
Social. Mother-in-law stories. Mother-in-law stories where I have been married in your home state for the last 8 years and have no progeny. And then the one time you see me pregnant, I am trying to discuss whether I should or should not. Yeah. There are also religious issues. We are a country where we have Christianity, Islam, and we have Hinduism. And we also have to consider the religious angle. Is it even permissible in your different religions that you practice? There are legal issues. There are legal implications. We are allowed to have a medically recommended termination, but to a certain point, yes. We can't cross at 24 weeks now. We are talking about legally terminating. That's also a legal issue. That's why we want to come in early for the legal part, the social, the ethical part, where you're having a mother. Is it ethical to discuss with a mother who's lost 10 pregnancies and here comes the final one, which has a chance of getting to the end, and then you're telling her it will be very difficult to take care of this patient. And yes, you have to have that conversation, and that's why we say you have to detach yourself from your beliefs. As a genetic counselor, you're supposed to detach yourself and offer the best knowledge. Support that family to make a decision. Don't interfere. Don't say, I'm Catholic. I'm Catholic, you're not supposed to even think about it. Yes, don't even dare. I'm already inferring. I had a couple, they were also Catholic, and they had a son who was challenged, and the second son was also challenged, and she was pregnant again. And now we did the test, and it so turned out that this child she was carrying was going to be challenged. And she was Catholic, and I'm Catholic. And now we were there discussing our Catholic religion, what's going to go on here.
And the limited options it gives you.
The limited options. And you can see that it can't get in. Because she was like, I am exhausted from my 2 sons. Yeah. I'm totally exhausted. I can't have another one, and I'm going to add to this burden. So I told her just to have a discussion with the catechist and her parish priest and make her own decision. But it wasn't mine to make. It is me to tell her this is what is happening
for you.
and just support her. If she decides I'm going to have this child, then I'll tell her, okay, that's good. Now let's get a neurologist in place. Let's get a cardiologist and neonatologist in place. Let's prepare. We're going. Where do you want to deliver? Everything will be put, like, open it up for that mother.
So with this difficult diagnosis, the ethical dilemmas, legal challenges that you have to go through, how do you handle that as Dr. Mutinda? Because every day is not easy. And I've been to your clinic and
It's fun.
yeah, sometimes I leave heartbroken because, you see parents with, as you say, the funny looking child, and I just see the difficulty even in handling the child just within the waiting area. So how do you handle it? Because I come as a patient, but I feel I left with a heavy heart. I live with a heavy heart. So how do you handle it? And you do this every day?
No, I don't do it every day. Trick of trade, I don't do it every day. And I think that's something people need to understand. I'm also human. I'm a very human. Just like you feel heavy-hearted, I also feel the same. So I try to pace myself. I have an assistant who also paces me. So there are days I will not be available. Not because I don't want to be available, but I need to deal with something that I think I've just learned something called BTS. Behind the scenes.
Behind the scenes.
So behind the scenes, I have a lot of people who take care of my psyche, who take care of my physical health. I have a wonderful husband. So sometimes he just walks in and says, oh no, and spad it now, And sometimes that is important. So in genetics and in genetic counseling, even when you have a genetic counselor, which we are trying to set up, there has to be pacing. Because you're also dealing with a human being. I'm a human being on this side. I'm a woman. I'm a mother. I've been pregnant. I've lost pregnancies. So I don't want, I leave those emotions through them. So I will see patients on Tuesday, and the way I leave the office will determine how Sharon will book my next appointments. And she knows their days. She'll just cancel everybody and tell them she's not available because I need to get back. Yes.
You need to go and recalibrate
And
and reorient yourself back
to center, and also sometimes you just need to walk away from the situation, shake a little, then come back.
Yeah, because I've seen it's not easy being in your clinic, not at all. So when mothers come to the clinic, and now you're planning for future pregnancies, what conversations do you have? And I'm just thinking about, say, the couple that had to terminate, or the couple that had gone ahead with a pregnancy, the child is challenged. What kind of conversations and options are you discussing for a future pregnancy?
So we're discussing risks. We're discussing risks, and there's something called genetic risk. And genetic risk can be individual or population risk. All of us as humans have a population risk of getting a disorder. And then we have personal risk. You have had a child who has sickle cell disease. It means that two couples are carriers. And if you're going in to have another child, because the child with sickle cell is now called the proband, has arrived, the risk to the next child is even higher. So we are discussing those numbers and having you make a decision. We are getting very lucky in Kenya. We have fetal maternal experts. And the population is growing. When I came in, it was only one. Now there are many fetal maternal experts. So we have people who are speaking your language. So if you're having a high-risk pregnancy, we have people who are actually trained to take care of a high-risk pregnancy. I know at Aga Khan, they're able even to transfuse the child in utero. So we can have that conversation about, do we want to go this way? Sickle cell is now becoming a treatable disease. So we are now trying to say, how do we link you to treatment? So we found a patient just recently that the mother and the father are carriers of a variant that causes galactosemia, which is an inborn error of metabolism. So we are saying, if you get a child, the moment you give birth, we test. and we start replacement therapy. So we are discussing your options. We're discussing IVF. We're discussing, do you really need to have a child of your own?
Or can you adopt?
Or can we just go adopt?
Yeah.
Yes. You know, we are discussing a whole range. What is available? What can we do? Yes. And what is your family situation that maybe is your mother-in-law supportive enough of, say, adoption as an option? Or she's adamant her son has to have, you know? Yeah.
Are the mother-in-laws this powerful in terms of deciding
I think
what decisions
traditionally
I make as a woman?
Let me declare I have a perfect mother-in-law who doesn't really interfere, but I know some can be very hard to deal with. And it's not generally a mother-in-law, specifically their mother-in-law, but we're just talking about family.
The extended family,
yes, family per se, yes.
So apart from, of course, the family and the mother-in-laws, the mothers-in-law, the input from, the close family and people around the couple or the woman, what other barriers or stigma stop people from seeking genetic counseling and testing?
I believe most of it is modern day AI. Modern
What do you mean?
AI. So there's this thing called gene for 2 or 2 for gene or something.
Is it 23?
23 and me?
Yeah, I think it was 23.
Yes. Yeah. So you have such, we call them direct-to-consumer products, where we have almost said that we don't want the physical doctor, we don't want the physical genetic counselor, that these patients can order this tube and then they'll send their saliva and then the results will come. And really, we've not talked to the patient and told them that 23andMe or someone has nothing to do with diagnostics. They can't tell you anything.
What do they tell me?
They tell you you're half Asian.
Like my race,
Your race
and
is
genealogy.
Exactly. And,
Okay.
and unfortunately, when you go behind the bioinformatics, it depends on what they have in their inventory. So they're comparing you to an inventory that is theirs, not the global, not you. So there's a lot in a genetic test. It's not taking blood, give me the results. You'll get the results, but I have to do a correlation. I'm seeing Mercy Corriel, and then the results say Mercy Corriel is from Canada. And I'm like, nah.
And I'm just from here, Kericho.
Imagine. So we need to have a conversation with this result. What's happening here? Yeah. Did Mercy Corriel's mom or dad go to Kericho and coming from Canada or something? So there is a lot behind there. So the AI situation where we have a lot of, I want to call them briefcase setups, where we feel empowered enough to go do a test. I think that's also a barrier to come into genetic counseling, because even my own colleagues might want to just shortcut and just go do the test, and then you're stuck with a result. I've had a very bad situation where the mother did the genetic test because it was recommended by the doctor, who told her she needed it, and she did indeed needed it, but she was not prepared for it. And then she got the results. The doctor looked, and it was not good, and he didn't know how to explain it, and then told her, now go book.
Go to Dr. Mutinda.
And she sat in my office and told me I'm suicidal. She wanted to kill herself. And it's because we didn't prepare her. And that's what genetic counseling should do. Sometimes you can come into a genetic counseling situation, and I refuse to do the test because I feel you're not there yet. So it's important for us to go into genetic counseling and know what we need to do.
Okay. Would say I've come to you and you've given me a diagnosis that has broken my heart, probably, had a termination. I'm thinking that would scare me from coming back. I'll have PTSD.
There are people who see my door and start crying.
Yes.
So sometimes you have to wonder whether you are doing some good work. My teacher used to say, the mark of a geneticist that's doing well is the families that stay together. I'm happy that most of my patients stay together and we still have conversations after. Sometimes it's hard when you tell a patient, I hear you, you need a test. I know you do need a test, but you're not ready. And I'm not going to offer it. And sometimes they short circuit me and go to someone else who will offer the test. But that conversation needs to happen. That relationship needs to happen. And after that is said and done, we need to have a link up. I link a lot with the psychologist and the psychiatrist to lift. Because mine is a service. It's a counseling service. It's not therapy. So sometimes a patient does need the therapy, the depression, the anxieties that follow. There's need now to move to mental health specialists who are able to link up with me and take over until the patient is well. Sometimes we have a discussion and the mother wants to get pregnant immediately. Yes, I've lost that one. You said the risk is 50-50. Let me try the next 50. And I'm like,
You need to wait.
You wait, and the next time I'm going to discuss this with you, and we've had those discussions with many of my patients, you have to bring me a note from your psychologist that she feels that you're ready. Because it's a lot. It's a lot.
From medical school, one of the things I learned, and you probably did, is that the best surgeon is the one who knows when not to operate. Yes. So I guess it also applies. So what do you think needs to happen in our health system or the health structures, our hospitals, so as to make this conversation part of everyday consultations, and meetups with doctors, even from the medical officer level, your GP. What do you think needs to change?
I think there's this thing called UHC.
Universal health coverage.
Yes. In order for us to have totally universal health coverage, you have to think about the economics as well. What is it going to cost the health system to take care of us universally? And in order to know what's going to cost you, you need to know what your risks are. So essentially, we need to move away from being scared of genetics and being scared of screening for genetic conditions. Because I'll tell you for a fact, in England, these children are diagnosed in utero. Mother decides to have the child. The insurer knows this child will need a cardiologist, will need an endocrinologist, and they're all lined up, and the clinics are already. So already that money is factored in. In our system, we tend to be reactive.
It's usually a surprise.
Yes, surprise. Cardiology, surprise. We can't deal with it. If you're going to do universal health system correct, you can't deal with surprise. You need to plan. You need to actually look what awaits me so that you can plan. Say, for example, now we are talking about hypertension and communicable diseases, hypertension, cancer. We are surprising each other with how many people who have hypertension. And how many
we have not diagnosed all of them.
Yes. And surprise, surprise, we have cancer. Then now our reaction is to go and put in our health insurance a pocket for this money. It'll never be enough. How about not getting them sick? How about evading that whole process? So if, let's say, going back to the Angelina Jolie issue, if my parents had cervical cancer, had breast cancer, and at 18, I know I have a risk of getting breast cancer by 34, wouldn't I do something? I'd rather go meet the surgeons, remove the breasts, get some fake breasts to my liking, and never have to go to an oncology ward. And guess what? The insurance will not pay. And
they won't.
They won't pay, and it will be cheaper for everybody. And what is the quality of life here? I will see my grandchildren. Yeah. So we have to have that conversation in that idea and say and stop looking at it in the fact that it's invasive. You can't have both things. Yes.
Okay. So what's your message today to anyone listening or watching and they have questions about their next pregnancy or their child's development or their risk for even cancer or any other genetic disease? What would be your message to them?
Let's have a conversation. Yes.
Let's talk.
Let's talk. Let's talk. Let's see what's there. Is it real fear? Because sometimes the fears are not real. We're just fearful. So let's have a conversation. Is it real? And if it's real, so what are we going to do about it? Then we take it from there.
Ignorance is no longer bliss.
It's not bliss.
Thank you very much, Daktari. Thank you for your time. Thanks for having this conversation about genetic counseling. It has gotten me thinking about a lot of things. I'm not saying I'm old, but yeah, it has gotten me thinking about a lot of things, that we take for granted, that we could do. And obviously, we could be those first people to make sure that people have that information so that they can make informed choices. So thank you for your time today as we talked about genetic counseling. And thank you, Wahu, for sharing your story with us. Wahu's story is one of courage, choice, and clarity, but it's also a glimpse into a future where science meets compassion, where no mother is left to walk the journey of uncertainty alone. Non-invasive prenatal testing offers more than answers. It offers peace, it offers time, it offers choice. Yet in Kenya, that peace remains out of reach for many parents because too often the difference between fear and freedom is a test that is too expensive to take. And so the question is, if we can offer parents knowledge that can change how they carry life, why shouldn't every mother, every father have the chance to know? You have been watching and listening to Willow Lifeline Dialogues Code of Life with me, Dr. Mercy Korir. If this episode opened your mind or moved your heart, share it with someone who might need it. Until next time, keep asking, keep learning, and keep holding on to hope.